believe it's time to get started. So I'm here to welcome everyone from all corners of the world. It's so nice to have you here this morning or afternoon or evening, whatever the case may be. My name is Vanessa Sarche, and I work as an associate director in the ASCO International Affairs Department. It's my great pleasure to be here to kick off this event. We have a special collaboration with the Postgraduate Institute of Medical Education and Research, PGIMER, in Chandigarh, India, and we have committed to working with them together to create several educational opportunities for oncology professionals. So we have a really great webinar program planned for you today. I'm really excited. We have several esteemed speakers and participants from both the United States and India. So I'm really looking forward to the discussion today. As a little bit of background, I thought I'd share that I met my co-host and friend, Dr. Gaurav Prakash, in 2012. He was a recipient of the ASCO International Development and Education Award, IDEA, the IDEA Award. And in that year, he was actually paired with an IDEA mentor named Dr. Bruce Chesson, who has been invited and has graciously accepted the invitation to be our keynote speaker today. So it's just wonderful to see that relationship continuing on today through this program. And I'm really excited for the discussion to come. So without further ado, I'll go ahead and pass it over to Dr. Prakash. He's a medical oncologist and additional professor at PGI in Chandigarh. Thank you.
Thank you so much, Vanessa, and hello, everyone. Just let me share a screen. So my name is Gaurav Prakash, and I am working at Postgraduate Institute of Medical Education and Research, which is located in Chandigarh in India. And we are quite delighted to organize this webinar on lymphoma in close collaboration with the American Society of Clinical Oncology, ASCO. So as Vanessa mentioned to you, this webinar is being webcasted across the globe, and we have participants not only from India, but from other countries and other parts of the world. Just to introduce our institute better, so we are situated in Chandigarh, which is a very nice city in northern part of India, which is quite close to New Delhi. And I would like to mention that our institute, which is Postgraduate Institute of Medical Education and Research, it is the second largest multi-speciality tertiary care center in India. And I can very clearly say that PGI is one of the leading torch bearer of medical education in India. We offer large number of postgraduate and fellowship programs, including program in clinical hematology and bone marrow transplant. And soon we are planning to start, training in medical oncology. So to further the cause of this medical education, we have collaborated with American Society of Clinical Oncology, and we intend to organize a series of educational events in the times to come. In the first edition of this collaboration of this activity, we have chosen topic lymphoma. Needless to say, lymphoma is one of the commonest hemat malignancy. It figures out in top 10 cancers, especially in male patients, and the incidence is rising, at least in the developing part of the world. The beauty of lymphoma is that despite having advanced stage, there still remains a high potential of cure if managed optimally. I personally believe that in the years to come, we will enter the golden age of lymphoma management, going by the exciting new development of cell therapy as well as newer treatment which are coming by. Lymphoma has significant pathologic, geographical, and genetic heterogeneity, which makes it very intuitive and very interesting disease to study and learn. Just to give you an example of this geographical variation, I am going to present this graph to you, and this is India-specific data. You can see right at the top, we have New Delhi. It seems an outlier where the incidence rates are around 6.2 per 100,000 population. But if you see rest of the India, it is kind of a cascade. The point I want to highlight with this graph is that if you see the regions of India which report higher incidence of lymphoma, they seem to be clustered in the southern and western parts of India. On the other hand, if you see the parts of India which report least incidence of lymphoma, they all seem to be clustered in the eastern part. So this is the Indian kind of mapping. If you see the global data, it seems a similar pattern exists in the world as well, where maximum number of incidence of lymphoma patient is clustered in the Western country. And as you move from Western countries to East, the incidence of lymphoma falls. So with this brief introduction about our program and the lymphoma topic, it is my pleasure to show you the program for today. And we have two very eminent hemato-oncologists as a speaker, as guest speaker, who are going to give talk on these two respective topics. And to introduce them formally, it is my pleasure to invite two chairpersons. We have Dr. Pankaj Malhotra and Dr. Naveen Khatri. Dr. Pankaj is a professor and in charge of clinical hematology at PGI, and Dr. Khatri is professor and deputy director at TMC, Mumbai. Over to the chairpersons. Thank you.
Okay, thank you, Gaurav, and I welcome all, especially our guests from US who have, spared time to educate us and share their knowledge with us. And we thank you very much, ASCO, as well as our speakers for that. And the keynote speaker for today is none other than Dr. Bruce Chesson, who is a senior hematologist oncologist, and he was formerly professor of medicine and head of hematology at Georgetown Lombardi Comprehensive Cancer Center, Washington, DC, and he's currently scientific advisor to the Lymphoma Research Foundation. He has seminal work on lymphoid malignancies, Lugano classification for PET-CT-based staging and response evaluation of lymphoma. So I present to you Dr. Bruce Chesson, who would be speaking on chemo, moving to a chemo-free world for lymphoma patients. Dr. Bruce Chesson, please. Thank you.
Thank you. And now to find the slides. Just a minute here. There we go. Okay, well, thank you very much for this honor to be the keynote speaker at the inauguration of what should be a wonderful series of educational opportunities. And I remember Gaurav fondly, always a very interested, very curious young chap. And it's great to see him mature into an established hematologist oncologist. Today, I'm going to talk about something that I'm pretty passionate about, and that is the road to a chemo-free world in patients with lymphoid malignancies. It's pretty obvious that patients don't want chemotherapy, and this is a little bit of the history of why they don't want it. Chemotherapy started actually in World War I and World War II with chemical warfare, with the Germans dropping mustard gas on the Allied forces, leading to skin ulcerations, blindness, lung damage, nausea, vomiting, and it caused cancer. But there was an important incidental observation, and that was these persons also developed lymphocytopenia and shrunken lymph nodes. So in the 1940s, Goodman and Gilman of the biochemistry textbook fame made a derivative of mustard gas, nitrogen mustard, and they injected into lymphoma patients. And lo and behold, the lymph node shrunk. It was temporary, but it was the first demonstration that a systemic therapy could actually treat a cancer like lymphoma. And now the derivative of mustard gas, the alkylating agents, are the mainstay of most of our chemotherapy concoctions. They're in the red here, and whether it be non-Hodgkin lymphoma, Hodgkin lymphoma, CLL, or whatever, they're everywhere, and they need to disappear. The first step towards getting rid of chemotherapy actually dates back into the 19th century, 20th century, to the work of Paul Ehrlich, who was the father of modern immunology. And he said, you must take aim by chemical variation. The effect of an antibody in the serum is that it causes no impact on the person themselves, but affects the tumor or the parasite, as he called it. And he created the term the magic bullet. So it would kill the parasite and be gentle on the body. And in his monograph from 1890, the ovals are tumor cells or microbes or whatever you wanted to attack. And you can see how the magic bullets bear an uncanny resemblance to the structure of what we now think of as monoclonal antibodies. Clever chap. And this just shows a description of all these surface proteins that we now have available and are increasing in number as we recognize them on the cell surface. And this is the first of three compartments that I'll be talking about, the cell surface, as a target for non-chemo-based therapy. Now, in the old days, when you wanted an antibody, you just pulled up to your local horse, plugged in, and got some horse serum. Fortunately, we've moved beyond that. And the development of therapeutic antibodies started with the concept by Ehrlich, and then Kerler and Milstein developed methods to generate an adequate supply through hybridoma technology. And then you had to find your tumor-specific target, and this was first identified by my friend Lee Nadler back in 1981. He called it B1. And B1 was, in fact, what we now call CD20. For decades, we compared one chemotherapy concoction with another chemotherapy concoction and made no progress in the treatment of large cell lymphoma, up there on the top left, or follicular lymphoma. It wasn't until we added a biological, a non-chemotherapy agent, that we made progress. Bertrand Coiffier with CHOP versus R-CHOP, and a number of investigators, including Wolfgang Hideman, also showing the benefit of adding rituximab to virtually any chemotherapy regimen, prolonging patient survival. But not good enough, particularly here. You can see the curves keep going down and down, and we need to do better. But that was in combination with chemo. We're trying to get rid of chemo. This is a long-term follow-up of a Swiss trial in which patients were randomized to short versus prolonged rituximab maintenance. And these are 10-year data showing that without chemotherapy in this patient group, 80% of patients were alive, and more than 40% were event-free, and a third of the responders never needed additional treatment. Without chemo, we're getting wonderful results. But we still need to do better, and one thing we can do is develop a better anti-CD20. Obinutuzumab is a type 2 anti-CD20 in contrast to rituximab, which is a type 1, and it has high ADCC, antibody-dependent cellular cytotoxicity, and cell kill, and has been shown to be the preferred anti-CD20 for patients with chronic lymphocytic leukemia, not as clear in other histologies. Well, back in about 15, 18 years ago, our group, which was then called CALGB, decided that we're really going to move forward with non-chemo-based approaches to follicular lymphoma. And in those days, we didn't have some of the tools we currently have that I'll be discussing later, but we had several monoclonal antibodies. So we developed combinations of monoclonal antibodies. The first study was Galiximab, an anti-CD80 plus rituximab. And you can see that depending on your Flippy score, the response rate was as high as 92% with 75% complete remissions. And even in high-risk patients, 55% responded with almost 30% getting a complete remission. And this correlated with progression-free survival, which for the low and intermediate patients was quite long. And in fact, I have patients today, 15, 16 years later, still in complete remission from this regimen. And overall survival has been excellent. Our next was Eprotuzumab, the anti-CD22 in rituximab. We got almost 90% response rate with over 40% complete remissions. And once again, correlated nicely with Flippy group. And the overall survival was outstanding without chemotherapy. Those are just your basic antibodies. Well, we've also looked at methods to augment the activity of antibodies. One thing has been the antibody drug conjugate, shown schematically here. You bind an antibody to a poison. If you injected that poison into the patient, there'd be no more patient. Here, what you do is you bind the toxin to the antibody, and here it binds to the cell surface, is taken up into the endosome, where the poison starts to be released, into the lysosome, eventually causes DNA strand breakage, microtubular disruption, and lo and behold, a dead cancer cell. And we have a number of these antibody drug conjugates approved for lymphoma therapy. The first one was brentuximab vedotin, the anti-CD30, which in a study we published back in 2012 in patients with Hodgkin lymphoma who had failed a stem cell transplant. 3/4 responded, including a third with a complete remission. Long-term follow-up of these patients shows that about 10 or 15% have never relapsed out 6, 7, 8 years later and may be cured without any further therapy, particularly no chemotherapy. The most recent one to be approved by the US Food and Drug Administration, or FDA, is loncastuximab tesirine, which has activity. It's an anti-CD19 antibody drug conjugate. About half the patients respond, and about a quarter will get a complete remission. And these are relatively durable, although no evidence of cure. It does have modest toxicity, and newer ADCs are in development. So that's the first sector, the cell surface. Now we have the intracellular pathways. And there are a number of these which are downstream from the B cell receptor complex. And I'll talk about a number of these in a minute. But as you can see, there is the SYK pathway, or spleen tyrosine kinase, BTK, or Bruton tyrosine kinase, PI3K. Then there are the mitochondrial-based and a number of other pathways. And we have loads of drugs, first, second, and third generation, that targets these pathways, which I'll get to shortly. I think the first drug that really gave us enthusiasm was ibrutinib, the BTK inhibitor. And after demonstrating first in CLL that it had major activity as a single agent in the relapsed refractory setting, it was studied up front. And this is a study from the Alliance Group, formerly CALGB, comparing ibrutinib rituximab with ibrutinib alone against bendamustine rituximab in older patients. And you can see that the progression-free survival and also the overall survival favored the non-chemo approach over chemoimmunotherapy without much worsening, in fact, less toxicity. In younger patients, ibrutinib rituximab was compared with FCR, which is a more aggressive form of chemoimmunotherapy, and demonstrated a longer freedom from progression and a longer overall survival. So this has led to the general agreement among CLL folks now that chemoimmunotherapy no longer has much of a role in the treatment of either relapse refractory or previously untreated patients with CLL. And it is a totally chemo-free world. Now we have second generation BTK inhibitors. The first one was acalabrutinib. And in this study, in patients who were previously untreated, the Elevate Treatment Naive or TN trial, you can see that acalabrutinib or acalabrutinib plus obinutuzumab really wiped up chlorambucil obinutuzumab with respect to progression-free survival. Not so much overall survival yet, but the follow-up is still relatively short. Now, where does this fit in with ibrutinib? Several studies have now compared the second generation BTK inhibitors with ibrutinib. This is the Elevate Relapse Refractory trial. The primary endpoint was non-inferiority of progression-free survival, and you can see the curves are superimposable. In addition, acalabrutinib had fewer cardiovascular effects and therefore is probably a more desirable BTK inhibitor. A newer one is zanubrutinib. And once again, this was compared to ibrutinib in relapsed refractory CLL. The prior study was in high-risk patients. This is in all patients, and you can see the overall response rate is higher. And on the right is the progression-free survival, which is longer. Here we have 83.7 versus 69.1. You can see the difference in the curves, and it was less toxic than ibrutinib. So now we have several BTK inhibitors, which are at least as active and less toxic, and all are better than chemotherapy. And it's not just in CLL. This is zanubrutinib versus ibrutinib in Waldenstrom, the so-called ASPEN study, where the activity was comparable between the ibrutinib and the zanubrutinib. But down here, you can see the likelihood of cardiovascular events, atrial fibrillation, and flutter. The red is the zanubrutinib over time, and the blue is ibrutinib over time. So it's associated with fewer adverse effects. And the response rates of 90% certainly make it a desirable agent. Also, let's look at marginal zone lymphomas. This is the so-called Magnolia trial with zanubrutinib, with overall response in extranodal of 68%, nodal of 84%, and splenic 75%. That's at least as good as we get with chemoimmunotherapy, with far fewer toxicities. And here's the progression-free survival. And you can see that even though these were relapse refractory patients, there were 80% of patients progression-free at 6 months and 70% at 9 months. Longer follow-up is eagerly waited for. And we have another class of drugs called the PI3 kinase inhibitors. In the US, we have 4 of these approved. The first was idelalisib, then duvelisib, then copanlisib, and most recently umbralisib, which also targets casein kinase 1 epsilon, which is in part responsible for its improved tolerability compared with the other PI3 kinases. Now, umbralisib has recently been approved in the United States for the treatment of indolent lymphomas, particularly marginal zone and follicular, where it has a response rate approaching 50% in patients with a median of 3 prior therapies, which is very impressive. And it's a pill, and it's well tolerated. And this is duration of response. For marginal zone, the median is not reached. For follicular, it's almost a year. And for SLL, it's a year and a half. This has been combined with another anti-CD20 called ublituximab, the U2 regimen, and compared with chlorambucil obinutuzumab in both treatment naive and previously treated patients, and those with a prior BTK inhibitor. The U2 was superior to chlorambucil obinutuzumab, and I expect this combination will be approved by the FDA within the next few months. All better than chemoimmunotherapy. This is the progression-free survival in the treatment-naive population. You can see almost 80% are progression-free out of 2 years and previously treated, and half of the, those are previously untreated, and half of the previously treated patients are still without progression. Results rivaling chemotherapy. Another active PI3 kinase is copanlisib. The difference is this one is administered intravenously. And these are very recent results presented at ASCO this year. One of the randomized trials out there called Chronos 3, where copanlisib and rituximab was compared to placebo and rituximab. And you can see how the curves are markedly different, highly significant. So we have another effective PI3 kinase inhibitor. And it's reasonably well tolerated other than hyperglycemia and hypertension that are transient. Another important drug is one that targets BCL2, and that is venetoclax. And after demonstrating impressive activity in relapsed and refractory patients with CLL as a monotherapy, including those with the dreaded 17p deletion, it was moved up front. And this is the CLL-14 trial that got it approved as frontline therapy, comparing venetoclax obinutuzumab with chlorambucil obinutuzumab. Just as an editorial comment, chlorambucil obinutuzumab as a comparator is like kicking a sick cat, because pretty much anything can beat it. But here we go. Veng, the G for GA101, the original name, was markedly superior with regard to progression-free survival, but not yet with overall survival, and was well tolerated. Well, if you've got a good drug like ibrutinib and another good drug like venetoclax, why not put them together and see what happens? And this has been done first with the Captivate trial, where response rates were extremely high, but I'm just showing you this one slide of undetectable minimal residual disease. 75% of patients became undetectable with this combination, which correlated with outcome. And this regimen has recently been reported compared to chlorambucil obinutuzumab in the GLOW trial, and it was markedly superior, and I expect will be approved in the near future. Well, this regimen is not just effective in CLL, but has demonstrated markedly important activity in mantle cell lymphoma. These are patients with relapsed refractory disease, and you can see that the response rate is over 80%, with more than 60% of patients achieving a complete remission. Again, better than anything else we've had for relapsed refractory mantle cell, where drugs like bortezomib and lenalidomide had response rates in the 20 to 30% range. Well, here's another pathway, XPO1, exportin 1. Exportin 1 is the major nuclear export protein for tumor suppressor proteins and proto-oncogenes. And what happens is, when you have an intact XPO1, these proteins and substances are moved into the cytoplasm. But when you inhibit it with a drug like selinexor, they stay in the nucleus and they kill the lymphoma cell. And selinexor is an oral, relatively well tolerated at the new and improved dose inhibitor of XPO1, and the overall response rate was a modest 29% with 13% complete remissions, but it is a pill you take once or twice a week and can readily be combined with other agents that are non-chemo. If we're looking at the epigenetics, we're moving deeper into the cell. Recently approved was a drug called tazemetostat, which targets EZH2, which is a regulator of gene expression and plays a critical role in multiple forms of cancer. Tazemetostat is a reversible oral inhibitor. You can see here, when it's active, you get transcriptional repression. When you inactivate EZH2, you get transcriptional activation. And this was the study that achieved approval for this drug. The overall response rate in the mutated patients was 69% versus 35% in unmutated, with a longer progression-free survival. However, careful scrutiny of the demographic shows this was a more favorable group of patients. And with or without the mutation, the response rates are fairly close and the progression-free survival is identical. But it is active and has virtually no toxicity. And it is a pill and not chemo. Well, the third sector is the microenvironment. And the importance of the microenvironment is becoming increasingly notable. And in this schema from Steve Ansell's group, it just shows that there are a number of upregulating and downregulating positive and negative cells and proteins within the microenvironment that impact the growth and proliferation of lymphoma cells. One of the most well-known of these agents that targets the microenvironment is lenalidomide, the second generation immunomodulatory drug, which has effects on T cells, NK cells, malignant B cells, and other microenvironmental factors. You people who take care of myeloma are quite well versed in the use of lenalidomide. Lenalidomide was active in relapsed refractory lymphomas, particularly indolent lymphomas, and was moved up front in what was called the relevance trial, which I consider to be the most positive negative study in lymphoma. I say that because it was R squared, or rituximab and Revlimid, lenalidomide, versus R chemo, R CHOP, R CVP, R bendamustine. And the response rates were the same. This is CR rates here, 55, 58. Overall response rate, 84, 89. Progression-free and overall survival were the same, and there was less toxicity with the R squared. The problem was the study was designed as a superiority trial in over 1,000 patients. Had they made it a non-inferiority trial, this regimen would have been approved by the FDA, and now it is not in the frontline setting, but has been approved based on the AUGMENT trial in the relapsed refractory setting. Here's the PFS overall survival for the relevance trial. Now, there is a new drug out there, tafasitamab. Tafasitamab is an anti-CD19 monoclonal antibody that is FC enhanced to have increased antibody-dependent cellular cytotoxicity, ADCC, increased antibody-dependent cellular phagocytosis, ADCP, and improved direct cell death. By itself, this antibody, which is a naked antibody, has about a 28% response rate. So the manufacturer was looking for a partner for this drug. And since the drug enhances NK cell function and macrophage function, they said, aha, what about lenalidomide? And this led to the regimen called LMINE, the combination of TAFA and LEN. And this was studied in patients with relapsed refractory diffuse large B-cell lymphoma, no chemo. If you look at the data, the overall response rate is 58% with 40% complete remissions, a median duration of response of 3 years, a median PFS of 1 year, and a median survival of almost 3 years. Relapsed refractory large cell lymphoma, no chemo. If you use it in second line, where it is approved in the United States, it has almost a 70% response rate, 50% complete remissions. Half of those remain in remission out beyond 4 years, raising the question, are these patients cured without chemo? Now, in the microenvironment, we have a lot of T cells, and they express PD-1. And the tumor cells, lymphoma cells, have the ligand, PD-L1, for example. And when PD-1 and its ligand interface, it impairs the ability of the effector cells to kill the tumor cells. And we now have a number of ways to get around this problem. We have several approved checkpoint inhibitors, the PD-1, PD-L1 checkpoint. Pembrolizumab and nivolumab block PD-1. Atezolizumab, durvalumab, and avelumab block PD-L1. Nivolumab was first shown to be highly effective in patients with relapsed and refractory Hodgkin lymphoma. The response rates were pretty much the same, whether the patient was brentuximab naive, had brentuximab after failing an auto transplant, had brentuximab before and or after an auto transplant. You see 65 to 75% of patients responded, including 16% complete remissions. Rather remarkable for a disease where we said, oh, after brentuximab, we're in trouble. There's nothing else. Then along comes the series of checkpoint inhibitors, which are now used not only in the relapse refractory setting, but are being studied in frontline as well. Well, we have brentuximab and we have checkpoint inhibitors. How do they compare? This is a randomized trial of Pembro versus brentuximab, and it shows that looking at progression-free survival, the checkpoint inhibitor is actually superior to brentuximab in relapsed refractory Hodgkin lymphoma. Now, the combination has also been explored, first in relapsed refractory Hodgkin lymphoma, where Ranjana Advani from Stanford recently published their follow-up data, where the overall response rate was 85% with this combination, no chemotherapy. The highest response rates we've seen in relapsed refractory Hodgkin lymphoma, and no chemo. And these are on top the progression-free survival, all patients in blue, and those who had a stem cell transplant afterwards. The middle shows that even primary refractory patients have about a 65% chance of benefit. And this is the survival of all patients, which is over 90%. Well, we like those data. So we designed the study of BV-Nivo in untreated Hodgkin with no chemotherapy. And we found an overall response rate of 91% with 65% complete remissions. Not bad, except the study did not meet its primary endpoint, and part of which was, I don't think we gave the nivolumab long enough. But still, it shows you can get away without chemotherapy in certain patients. Well, this is the fun one. This is one of the new checkpoints. CD47 is called the don't eat me protein. It is on the surface of all our bodily cells, so they're not consumed by macrophages. And it interfaces with macrophages through the SERP alpha checkpoint. Now, lymphoma cells and other tumor cells have a higher density of CD47 on their surface, which protects them from the macrophages. But we have drugs that block the CD47 SERP alpha checkpoint. They downregulate the don't eat me signal, and they upregulate the eat me signal and phagocytosis of the tumor cell. This is a study published now about 3 years ago, looking at one of the anti-CD47s. There are several of them out there now in rituximab. In large cell lymphoma, the response rate was 40% and 70% in follicular lymphoma. And the CD47 targeting drugs are now being developed further and combined with other agents. Still working on that microenvironment, one of the more exciting new classes of drugs are the bispecifics. Most of them target CD20 and CD3. And you can see, for example, here, looks like an antibody. The CD3 binds to the effector cell, the CD20 to the B cell, and approximates them closely to effect cell kill. There are at least 5 of these out there. They all look similar except for glofitamab, which is a 2-to-1 configuration. And epcoritamab is subcutaneous. The rest are intravenously administered currently, although there is a sub-Q preparation of mosunetuzumab in development. And they're highly active. These are some data with epcoritamab, and if you use the higher dose in this phase 1 trial, you get a response rate of 91% with 55% complete remissions in large cell and 80-60 in follicular lymphoma. The progression-free survival is intriguing. The follow-up is relatively short, but it is interesting, and these are relapsed refractory patients. The adverse events of interest include cytokine release syndrome. You get it in about 58% of people, but it's never serious or life-threatening. Neurological toxicity is rarely serious or life-threatening. And just came out, I think, this week or last week in the Journal of Clinical Oncology, was Martin Hutchings' paper on glofitamab, which with ramped up dosing in aggressive lymphomas gets you a response rate around 80%, 71% complete remissions. And in indolent lymphomas, somewhere around 80% as well, with about 2/3 of the patients getting a complete remission. And this is the time to a complete remission in indolent lymphomas very quickly, and aggressive lymphomas around 3 months. The duration of response, about 45% of patients are out there for perhaps a couple of years. This is duration of CRs, which is 75% are out here. And the progression-free survival needs some work. For the indolent lymphomas, the median is out here around 10 months, and the aggressive lymphomas is shorter. But we are now finding ways to combine even these drugs with others in a non-chemo regimen. The toxicities related to the glofitamab are here. Cytokine release syndrome is almost exclusively grade 1 and 2, and in less than half the patients, and there's some neutropenia, and the rest is barely noticeable. Now, mosunetuzumab has been looked at in follicular lymphoma, and this is another one with extreme high level of activity, over 90% in patients who are refractory to a PI3 kinase or who have failed prior CAR T-cell therapy. I'm going to finish just with a very quick mention of CAR T-cell because Loretta will be going into glorious detail on this in a moment. And she'll talk about how you leukapheresis the patients, you transduce the product, you expand it in vitro and reinfuse it. And there are now 3 products out there on the market in the US, actually, for large cell. There's a 4th for mantle cell lymphoma. There's axicabtagene, or axi-cell, tisa-cell, and lyso-cell. I won't go into the data and take away her thunder. But just to show you that even in follicular patients, the response rates are extremely high, very impressive. And the progression-free survival is long. Most interesting are data in which it's been compared with auto transplant. And 2 of the 3 studies that have been mentioned in the media thus far, the axi-cell, the tisa-cell, the lyso-cell, those 2 are positive against auto transplant in second line, whereas the 3rd product, the tisa-cell study, was negative. So I will conclude by saying we have an increasing number of non-chemo approaches available. These are targeted agents, immune therapies, and cellular therapies. In many situations, they are more effective and less toxic than chemotherapy. They've already replaced chemoimmunotherapy in CLL, follicular lymphoma, Waldenstrom's, and marginal zone lymphoma, and are poised to replace chemoimmunotherapy in mantle cell, diffuse large B-cell, and even Hodgkin lymphoma. But we have to develop rational combinations to increase their efficacy. And we have to identify biomarkers to help us personalize therapy. There are lots of them out there. Which one is better for which patient? And this will eventually lead to a highly effective, well-tolerated, chemo-free world for patients. And that should be the end of me and chemotherapy in lymphoma. Thank you for your attention.
Thank you. Thank you. That was excellent. Just excellent. I think, thank you, Dr. Chisen, again, for giving this overview and telling us what the future is going to be like. So we have, I think, a lot of questions in the chat box, and I hope you would be happy to answer those questions.
Delighted, pleased, enthusiastic, and happy.
So the first question is, has the quality of life been compared amongst patients receiving chemoimmunotherapy versus non-chemo regimens?
Yes. Several of these studies have compared quality of life, and in most of them, the quality of life was better, and in others, it was, in none of them is it worse. But in most of the studies, it's better to comparable. There have been a lot of quality of life studies because that really requires big randomized trials. But these are well tolerated, and these are better tolerated than your FCRs and your BRs and your R-CHOPs and all of those sorts of things.
Right. Thank you. So another question is about your opinion combining an initial chemo-free regimen followed by chemotherapy in large B-cell lymphoma, such as in SMART START trial.
There are several studies. I guess Loretta should be commenting on the SMART trial since it's coming out of her institution. There are investigators like Jason Weston at MD Anderson and the Europeans who are giving non-chemo regimens, sometimes followed by chemo, other times not, looking at populations like I would look at an older population. I like looking at older populations and those with comorbidities, combining things like tafasitamab, lenalidomide with a BTK inhibitor, for example. Those are out there. And the question is, do we really need to follow them with chemotherapy? We're doing that in Hodgkin, giving a couple of cycles of BV or Pembro, followed by ABVD or AVD actually. And comparing those two regimens is underway in the US groups. But the question is, do we really need chemo at all? There should be certain patients who you can give the non-chemo and then stop based on MRD or what have you. So, that's one way to do it, is to try and minimize the chemo by starting with a non-chemo approach. But the eventual goal is to get rid of the chemo altogether. And there are exciting data that I'm sure Loretta will show with CAR T-cell up front. And there are data with the bispecifics up front getting response rates in the 80+% range. So if we can figure out a combination like tafasitamab and a bispecific, for example, I think we'll get rid of chemotherapy in the next few years completely.
Right. Thank you. The next question is on MRD. So what is the role of cfDNA or ctDNA as MRD in these patients?
The shorter answer is we don't know. The longer answer is if you look at circulating tumor DNA before treatment in a variety of lymphomas, large cell follicular, it will predict outcome. If you have high versus low, no matter what you treat the patient, we give them all the same thing, there'll be a difference in eventual outcome. That's one way to do it. And that might help us distinguish which patient should get standard therapy versus an investigational therapy. For example, if you had a follicular lymphoma patient, you could predict ahead of time that they're going to have a 10% likelihood of benefiting from BR or CHOP or whatever. Why would you ever give them that therapy? You put them right on a clinical trial or treat them with a targeted agent. Now, MRD is also being evaluated during and more often following therapy. And in follicular lymphoma, it really predicts outcome quite well. And there are also limited data in large cell looking at this too. The question is, what do you do? If a patient has residual MRD, do you wait for them to clinically progress, or do you intervene immediately? And we don't know that. And that is a good topic for a clinical trial. Treat me now versus treat me later. But it does really, it's a much more sensitive predictor of outcome. For example, there are two follicular lymphoma trials. There was the gallium trial, frontline, ARC chemo, obinutuzumab chemo. And in the relapse setting, which I chaired, which was obinutuzumab versus bendamustine obinutuzumab in rituximab refractory patients. In both of those studies, the response rates were the same in both of the arms. But there was a PFS difference in the gallium, and there was an overall survival difference in gadolin, and that was correlated with MRD. And so if your MRD went down, your survival was up here. And even if you had a CR by imaging, but you were positive MRD, you were relapsing. So it is useful to predict, but we don't yet know what to do with that clinically.
Right. So that was the question from Dr. Anu Kumari. I hope that answers your questions. The next question is by Dr. Aditya Janjal. The question is, what should be the therapeutic approach for patients who fail to respond to a frontline chemo-free regimen?
And they do. And I've had patients when we're doing our clinical trials who failed chemo-free and did great with chemoimmunotherapy. That we have such a long list of other chemo-free drugs. If you fail R-squared, we have tazemetostat, we have umbralisib, we have other drugs. The problem is we do not have a biomarker to say this patient is going to respond to tafasitamab. This patient is going to respond to tazemetostat. This one's, if we had a biomarker, it would be really easy. We wouldn't have this problem. When I'm asked, what is the greatest unmet need in lymphoma? It's not a better drug for relapsed refractory patients. It is a better way to treat patients up front. And the only way we're really going to do that is if we have a greater understanding of the molecular biology and genetics of those patients, doing NGS and other tests to say, okay, you're better for this therapy and you're better for that therapy. Individualized treatment is where we're going. So if you fail one non-chemo regimen, we got lots of other non-chemo regimens. And in fact, in the old days, if you looked at the curves, I can see I'm frozen on the screen in a very unflattering, there we go. The dogma was each successive remission was shorter and less likely to get one. But now with these new drugs, we're seeing just the opposite. A lot of the time, subsequent treatments with a different pathway or a different mechanism of action actually get you a higher response rate and a longer duration of response. So we're still early in the learning curve here as to how to sequence these, combine them, and identify which patients are better suited for which agents.
Right. So the next question is by Dr. Gaurav Sharma, who enjoyed your talk. And his question is, please share if early versus late onset of relapse could differentially treated using advanced approaches. Which was, I think he's asking about the biomarkers, if that can differentiate how do we treat the early onset and late onset relapse.
Yeah. If you look at follicular lymphoma, for example, patients who progress within 24 months, the POD 24, do very poorly. Their 5-year survival is around 40% versus 80 to 90% for those who don't. And treatments like stem cell transplant don't work in those patients. Chemotherapy doesn't work in those patients very well. Those are patients who are better suited for the cellular therapies that you'll hear about and the targeted therapies such as bispecifics, where I think they will even help the early relapsing patients who in every situation tend to do worse than late relapsing patients. For example, if you get venetoclax-based therapy for CLL and you progress early, I wouldn't give it to you again, but if you progress after 2 or 3 years, then it's a reasonable approach to retreat. So when you progress, the time is critically important. Short relapses, 1 to 2 years, you got to go to something else, something different. Late relapses, you can give something similar that's less toxic or something different. But that is an important, it's not really it's an indirect biomarker. It's telling us something about the lymphoma. We don't know exactly what, but it is important.
Right. I think I forgot to invite Dr. Rahul Nathani and Dr. Srinivas Reddy. Dr. Srinivas Reddy is hemat-oncologist from Charlotte, USA, and Dr. Rahul Nathani is from Max, New Delhi, and Dr. Prashant Ganeshan also. So they're also the panelists, and they are also free to ask questions or participate in the discussion. So welcome both of you. The next question, the few questions are in the I think in the chat box. No, there's another question, and this question is: primary refractory early unfavorable Hodgkin failed 2 lines of chemotherapy. in CR after 4 cycles of Pembro now. Auto HSCT versus allo HSCT, no match sibling donor. So this question is by Sumit Mirk.
Or neither. What we know for some recent data, the long-term follow-up of nivolumab studies, is that there are 18% of patients who you treat with Nivo alone in that sort of setting who don't relapse out to 7-8 years. So what I tend to do now is to give them their checkpoint inhibitor and don't do anything immediately. Once they show early signs of progression, I mean, these are patients you assume have already had brentuximab, and now they're getting nivolumab. If they haven't had brentuximab, that's what I use. But for patients who don't have a matched donor of any sort, sibling unrelated, I would keep them on the checkpoint inhibitor until they show signs of progression, and then I would transplant them.
I have a tough task of timekeeping also. So I think
yeah, I think there are another couple of questions, and I think we need to ask some questions to Dr. Srinivas and Dr. Rahul, and I will ask them to share their experience. Dr. Gaurav, you can ask them the questions.
Yeah. So Dr. Srinivas, do you have a question ready? And you quickly just shoot it to Dr. Chesan, and then we will move on.
Yeah, thank you everyone for this opportunity. Thank you, Gaurav. Thank you, Dr. Chesan, for this great talk and going over all the important, immunotherapies and targeted therapies in lymphoma. I mean, we all hope for chemo-free treatment for lymphomas because of the long-term toxicities, including therapy-related myeloid neoplasms in the completely cured patients. So I would like your opinion on some patients who aggressive lymphomas, particularly like Burkitt, where we may need chemo to control the disease initially. So do you think we may need chemo in those kind of patients, even in the future?
Well, we used to say that about mantle cell lymphoma, that you really needed hyper CVAD-R from that bunch down in Houston. And now patients are doing fine with R squared up front, or R squared and a BTK inhibitor up front, even blastoid variants, where chemo doesn't work very well. In Burkitt, one of the problems, one of the good news and the bad news about Burkitt is it's rare. So it's hard to do a lot of trials, particularly in adults. But I think as we are swapping out drugs in our CHOP, like the polatuzumab vedotin story, which we didn't talk about, the Polarix trial appears to be positive, such that polatuzumab has improved the outcome up front. We're starting to get rid of drugs, chemo drugs, one by one, and substituting them with targeted drugs. There are drugs, I think you're not just, in a disease like Burkitt's, you're not just going to throw away all chemo because it's curative in a devastating disease. But just like in Hodgkin and in large cell, we're slowly whittling away the chemo and substituting targeted agents. And I think eventually we will get rid of chemo altogether once we have the right tools, whether it's CAR T. I mean, CAR T up front, for double hits, for Burkitt's and those things is certainly a possibility without subjecting patients to really awful chemotherapy. So we will get there. It's going to take a little longer in diseases like Burkitt, but we will get there. And Loretta will do it with CAR T.
Okay, Dr. Rahul Nathani, last question.
Yeah, no questions. Now, thank you very much, Dr. Chesan. It was a very nice talk and very nice interaction post this talk. Thank you so much.
Thank you.
Yeah, Dr. Chesan, there are few questions, but because of the time constraints, we may not ask questions here, and maybe in the chat box you can answer those questions. And for the next session, may I invite my co-host, Dr. Naveen Khatri, who is Deputy Director at Tata Memorial Hospital, Mumbai.
Thank you, Dr. Pankaj. At the outset, I would like to thank Dr. Chesan for such an excellent talk. I think it was very well received and the discussion after that. The next speaker is Dr. Loretta Nastupil. She is the Associate Professor, Department of Lymphoma, Myeloma, and she's also the Section Chief of the New Drug Development in the Division of Cancer Medicine at the MD Anderson Cancer Center. Her areas of interest is in new drug development for lymphoma and CAR T-cell therapy. Her talk is on the current status of CAR T-cell therapy for lymphomas. Over to you, Dr. Nastupil.
Thank you. I really appreciate the opportunity to share some quick insights on where we are with CAR T-cell therapy and where we might be headed. And it's hard to follow Dr. Chesson because he does such an amazing job, but I will try my best to walk you through kind of my perspective on CAR T-cell therapy. These are my disclosures. I highlight this because I remind myself frequently the dramatic changes that really have occurred in a relatively short period of time. So I've been at MD Anderson since 2013, and I remember early sitting in a lecture where CAR T was being described for the very first time by Kat Ballard, who was at Baylor at the time, and really having a hard time conceptualizing exactly what she was discussing. And again, within 7 years, this has now transformed our approach to chemo-refractory large cell lymphoma. With R-CHOP therapy, and we may now have a challenger, we'll hear more about the POLARIX study at ASH this year, but I would say that the majority of patients in 2021 are being approached with R-CHOP frontline. And you heard in the last discussion that there is room for improvement, but what we're lacking are predictive biomarkers that help us define those patients that are likely to fail R-CHOP. We know that at least 60% of patients are cured. When patients fail, oftentimes they were approached with second-line chemotherapy or salvage chemotherapy for those that were intended for high-dose therapy, auto transplant for those that achieved chemosensitive disease. That was the path forward. For patients who failed to respond to salvage chemotherapy or who had failed transplant, again, in 2018, really clinical trial was our preferred approach. If that was not an option, then we were generally pursuing either gemcitabine-based approach or best supportive care. We knew that the outcomes for those patients were likely to be poor, but this was a retrospective analysis utilizing data from MD Anderson, Mayo, and 2 prospective studies in Europe, highlighting that for patients who failed to achieve chemosensitive disease, the outcomes were indeed quite poor, with a median overall survival of about 6 months. Now, there is a sort of plateauing of this curve, so I do recognize that there are still some patients that do reasonably well despite failing to demonstrate chemosensitive disease, but it is a substantial minority of patients. And again, an overall survival of 6 months is generally what we were viewing these patients as a likelihood of outcome. Then comes along the CAR T-cell development, and as you've heard, the current FDA-approved products are autologous cells, so that does introduce some logistical challenges. We first have to identify a patient who is appropriate for CAR T. Either they have an FDA-approved indication or they're appropriate for trial. They undergo leukapheresis after either insurance approval or clearance for participation on a study. That can take anywhere from 1 to 6 weeks. And even at this time, I have a patient right now that we've been going on nearly 2 months, still trying to get insurance approval for a standard of care CAR. So though we've gotten better at the identification of patients and the approval process, is still quite heterogeneous and can be a major barrier for many. Once they're approved, there are questions out there. Do we have to tie leukapheresis to manufacturing? And currently in the US, with the exception of T-cell, we do. So for both axi-cell and lysis-cell, the collection of cells is tied to the manufacturing, and they cannot utilize cells that are sitting in storage. With T-cell, they can. Then the questions are being raised as to who's going to cover the cost of leukapheresis, and do we have the storage facilities to handle these products if we don't know if they will be utilized at a later time. So for the vast majority of patients, we do not undergo leukapheresis with the intent to manufacture CAR T at a later date. This is currently tied to when CAR T is considered the next line of therapy. There are differences in the manufacturing process. Specifically, axi-cel is manufactured from PBMCs using a fresh product. As I mentioned, T-cell can use a cryopreserved product, and Lysocell manufactures the CAR CD4 and CD8 CARs independent of each other. There are differences in how these cells are transduced. Axi-cel utilizes a retrovirus, so that's important for our patients. We learned this early on that whenever they fail axi-cel and they're being screened for clinical trials, because we exclude many patients with HIV, many of these patients were failing the antibody screen for HIV, and that caused a lot of distress for patients. And so again, we just remind people that this is not an indication that they will have HIV, but because a retrovirus is utilized to transduce these cells, it is entirely possible that they will fail an HIV antibody screen. They'll be negative for the confirmatory testing, whereas T-cell and Lysocell currently use a lentivirus. In regards to the CAR construct, they have similar extracellular receptors that target CD19. Essentially, all of these are exactly the same. There are differences in this transmembrane hinge region. There's been more attention paid to this recently, particularly as we now have either bispecific or dual CARs or cistronic CARs, how much distance from the cellular membrane to that receptor, how essentially flexible that receptor is, that may have an impact on outcome. But probably more importantly, with the available autologous CARs are the intracellular co-stimulatory domains. They all utilize CD3 zeta, but they differ in their co-stimulatory molecule. Axi-cel utilizes CD28, which leads to more rapid cytokine production. So you have a more rapid area under the curve or expansion, but also relatively rapid clearance, whereas the T-cell and Lysocell utilize a 4-1BB co-stimulatory molecule, which is a little more blunted expansion, but potentially more persistent. So we've been debating this over the last few years. Is one better than the other? In lymphoma, we currently do not know the answer to that, but it clearly does contribute to the differences in the acute toxicity. The ZUMA-1 study was a single-arm phase 2 trial that led to FDA approval of axi-cel. I'm going to highlight the differences in these studies and the differences in the population, because currently we do not have head-to-head comparisons of the CARs. And so again, we debate now that we have 3 available CARs, particularly within our institution, how do you choose amongst the available options for patients? So some of that boils down to comfort level or experience with the CARs in terms of toxicity management, but also I think important to recognize that these studies were conducted in different patient populations, and again, that may impact your treatment selection. Specifically with ZUMA-1, this enrolled patients that were chemo-refractory, so that was defined as failure to achieve chemo-sensitive disease after at least 2 prior lines of therapy or progression within 12 months of an autologous stem cell transplant. There was no bridging allowed in the ZUMA-1 study, but it was a smaller study in terms of number of participating sites. We enrolled a large number of patients on this study. So I can tell you from screening to leukapheresis generally was less than 3 days. So once patients were identified, they were rapidly leukapheresed. Manufacturing is relatively quick with axi-cel, so median time of about 17 days. So these were patients that were either stabilized with dexamethasone, commonly 40 milligrams a day for 4 days, or just monitored closely. There's a difference in the lymphocyte depletion utilized across these studies. Axi-cel uses cyclophosphamide 500 milligrams per meter squared, and fludarabine 30 milligrams per meter squared on 3 consecutive days. Slightly higher doses than what you'll see with the other studies, but potentially lower than what we're seeing currently with some of the allogeneic CARs. And they received a flat dose of 2 times 10 to the 6 CARs per kilogram. 99% of patients enrolled on the ZUMA-1 study had successful manufacturing of product, and 91% who were enrolled actually went on to receive their therapy. There is a lot of debate as to the intent to treat analyses that were not done in these studies. Many of these trials were conducted similar to transplant studies, in that the efficacy and safety population were restricted to those who actually had cell infusion. But again, because 91% of patients enrolled on the ZUMA-1 study actually had cell infusion, it's probably closest to having a complete data set in comparison to the other two I'll discuss. The best response rate in terms of overall response rate and complete response rate are reported in this slide. Important to note that these were the highest response rates we'd seen in this third line or later setting to date. So again, a little history lesson. At the time, if you had an agent with an overall response rate better than 30%, that was a potentially approvable drug. And so not only was the overall response rate far superior to 30%, we're seeing complete response rates in over half of the patients. This also was durable. With the initial reports, there was about 15 months of follow-up. We now have about 4 years of follow-up reported by Karen Jacobson recently, and about 40% of patients are likely cured in this third line or later setting. The Juliet study looked at T-cell. Again, it's a CD19 autologous CAR with a 4-1BB co-stimulatory domain. This was developed by Carl June at Penn and then licensed by Novartis. This is a large global phase 2 trial, so nearly 200 participating sites, so dramatically different from how the ZUMA-1 study was conducted. And as a result, there was a longer time from screening and enrollment of patients to actually infusion of cells. It was a median of about 56 days. So as a result, there were patients that failed to make it from enrollment to cell infusion. The vast majority were due to disease progression. Over a quarter of patients enrolled actually did not undergo cell infusion, either because they became too sick or they had to go on to alternative therapy. Bridging was allowed in the Juliet study, and that was at the discretion of the treating physician. The vast majority of these patients had chemotherapy-based options, and there was a difference in lymphodepletion. So the phase 1 that was conducted at UPenn, lymphodepletion was either not done because many of these patients were going into the study with very low lymphocyte counts, or could be any lymphoma-directed therapy. In the Juliet study, they tried to standardize this. So you had 3 options. You could do none. You could do fludarabine and cyclophosphamide at lower doses than what I just described in the ZUMA-1 study, or you could do 2 days of bendamustine, 90 milligrams per meter squared. So again, those are key differences. The other key difference is that the Juliet only enrolled large cell lymphoma and transformed from follicular, whereas ZUMA-1 also included primary mediastinal patients. Again, we see quite notable efficacy, higher or more durable responses achieved with patients who achieved a complete response. But again, about 40% of patients had a durable remission, suggesting again that we could potentially cure about 40% of patients. The Transcend was the largest study conducted thus far, so nearly 300 patients. Again, there are differences in manufacturing where the CD4 and CD8 are manufactured independent of each other, and then they're infused at a fixed 1-to-1 ratio. Again, we've debated whether or not that's important. That does not seem to matter with axicell T-cell. How this came about is there was a JCAR15 construct and study being conducted in ALL where they halted the study due to 2 patients dying as a result of cerebral edema. We actually had one of those ALL patients treated at our center. They then tried to troubleshoot what was causing the cerebral edema, dropping the fludarabine from the lymphodepletion. That didn't seem to matter. But whenever they then fixed the ratio of CARs, likely controlling for the concentration of cells, then that no longer was an issue and therefore led to JCAR17, which then ultimately went on to be explored further and was then FDA approved. A larger patient eligibility included in the Transcend study, not only transformed disease, but transformation from other indolent histologies, including CLL in marginal zone or others. Grade 3B follicular lymphoma was also included, and more generous baseline eligibility criteria, and that a creatinine clearance greater than 30, an ejection fraction greater than 40%, and no lower threshold for cytopenias. Again, this is the largest sample size, but even despite this, again, about 25 patients either received a non-conforming product or never made it to cell infusion. Again, maybe speaking to the fact that 4-1BB constructs might be more challenging to manufacture, potentially more room for error when you're manufacturing the CARs independent of each other. But again, at the end of the day, one of the larger data sets. And probably what jumps out to me about the JCAR lyso-cell construct is it likely has one of the most favorable toxicity profiles. Now, likely some unmeasured variables come into play, and that this was the third, and we had learned a great deal about toxicity management, and we're more aggressive in terms of mitigating acute toxicity, such as cytokine release syndrome or neurologic toxicity. And we know that if you introduce things like IL-6 blocking agents or corticosteroids earlier in the acute toxicity period, you're less likely to progress to higher rates of grade 3 or higher CRS. And that may then further impact the rates of grade 3 or higher ICANS. That being said, in my experience and some of the retrospective data analyses that have been done, the 4-1BB constructs are much better tolerated in terms of acute toxicity than the CD28 auto CAR. So I've highlighted the 3 studies that have led to FDA approval, specifically highlighting some of the important differences. We've mentioned the constructs. There were relapsed or refractory patients included in the Juliet and Transcend. Again, great debate as to which of these studies had the worst patient population. Some will argue because there was no bridging allowed in the ZUMA-1 study that selected out for better prognostic patients. I would argue not true, given the fact that it only took refractory patients. There were more patients who'd had chemosensitive disease and failed auto at one point on either the Juliet or Transcend studies. Probably most important, other than the response rates, which are probably more similar than different, are the number of patients that were enrolled versus treated. And again, the Juliet had the longest time from enrollment to cell infusion, resulting in a smaller portion of the patient population being treated. And you could argue that, again, the 2/3 of patients that finally made it to cell infusion were probably fairly good prognostic patients. At the end of the day, what we care most about is, can we cure patients with a single infusion? And my answer to that is yes, though it's not the majority of patients. Again, about 40% of patients are likely cured with CAR T-cell therapy. We spend a lot of time trying to figure out who are those folks that progress potentially early and quickly. Are there strategies to overcome resistance, or can we do a better job in terms of patient selection? So I'll walk you through some of those analyses. There are differences in toxicity, though you can't compare the numbers reported across the studies because there were different grading systems applied and different management strategies. So probably one of the most important developments in terms of toxicity management is the consensus statement that we now have consistent grading of CRS and ICANS with the more modern studies and modern practices. We don't have a consensus on management yet. That would be an important development. So there is still quite a bit of institutional heterogeneity in terms of management. But I would say in general, we're intervening earlier, particularly at grade 1 CRS that has been ongoing for 72 hours. And we are less fearful of the introduction of steroids, though again, we're cognizant of the cumulative dose of steroids, that again is still debatable as to whether or not that may have an impact on outcome. Because of all the debate surrounding the intent to treat analysis not truly reflecting the patients that would benefit the most from this therapy, we set out to report the standard of care outcomes. This was done early on after approval of axi-cell. There were 17 centers who had either participated in ZUMA-1 or were designated sites for axi-cell administration. This is not comprehensive of the entire US population, but again, a number of investigators that had participated on the ZUMA-1 study And with 17 centers, we identified nearly 300 patients. So outside of a tightly controlled prospective study, we do know that there's about a quarter of patients that never make it onto cell infusion. And that's either because they are too sick to actually make it the time required to undergo insurance approval. For those patients who actually get to leukapheresis, we still lose about 10% because they either die as a result of their lymphoma or they progress so rapidly that they're no longer considered candidates for cell infusion. You'll see some abstracts at ASH this year asking the question, what happens if you actually bridge patients? Because in the real world, there is bridging that does occur with axi-cell in an attempt to stabilize these patients while they're undergoing manufacturing. And at least one patient in this cohort of nearly 300 achieved a CR. I'd say early on, there was some consideration that if you don't have an antigen, you're not going to have T-cell expansion. And so we should potentially hold off on infusion. There's only one patient in this cohort that did not move forward. And there was one patient that medically deteriorated and was deemed not a good candidate to proceed. So among these 300 patients nearly, we have a efficacy and safety cohort of 275 versus 298. We looked at the baseline characteristics of those patients who were deemed appropriate for CAR T-cell therapy with a commercial product and potentially contrasted that with the patient population of the ZUMA-1 study. And there are some notable differences. Importantly, the successful manufacturing was the same with the standard of care product versus what was seen in the ZUMA-1 study, which I think is critical given how the ZUMA-1 was about 108 patients, and now we've nearly tripled that population size. Can they actually conduct a commercial product with all of the logistics that are challenging? We'll talk you through some of those, and the answer, at least with axi-cell, is yes. The performance status of these patients was much worse than what was included in the ZUMA-1 study. That's not surprising to me, but I think there is debate as to whether or not to move forward with patients who have very poor performance status. Oftentimes, if this is a rapid change and it's the result of disease progression, then again, there's debate even within our group as to whether or not to continue forward in those patients. There were less refractory patients included in the commercial cohort than what was included in ZUMA-1. And again, that's because we're just restricted to the label and not necessarily all of the important criteria, eligibility criteria in the ZUMA-1 study population. And as a result, again, a higher number of patients had chemosensitive disease at one point and undergone stem cell transplant. We also had the ability to look at some of the subtypes of large cell lymphoma that move forward with CAR T. And again, the breakdown in terms of GCB or non-GCB is outlined on this table. And again, probably overrepresentation of high-risk features such as double or triple hit and double expressors in this group of patients. Interestingly, nearly 40% of this population would not have qualified for the ZUMA-1 study, and outlined in this slide are some of the common reasons, including 40% that it would have failed multiple criteria, just outlining that prospective studies really do select out the very best patients. In clinical practice, there are patients that oftentimes just do not represent those study cohorts. And so performance status, we've highlighted cytopenias, were not infrequent. Thrombosis within 6 months, which was an exclusion criteria for ZUMA-1, was included. 7% had had a history of CNS disease, and there's been a separate analysis just looking at those patients led by the Mayo group. Renal insufficiency, lower ejection fraction, effusions, liver dysfunction, and even a small number of patients that had had prior CD19 directed therapy, which is becoming now an important discussion. As I mentioned, in the real world, patients do get bridging. Over half of patients who received axi-cell were bridged, and the type of bridging strategies employed included most commonly chemotherapy, steroids similar to what was done in the ZUMA-1 study. Radiation occurred in about 17% of patients. So we've looked at that within our group. Radiation might be a reasonable option given that most of these patients have failed at least 2 prior lines of systemic therapy. The goal of radiation is not to eradicate all of the tumor, but potentially to treat areas of bulky disease or areas that are going to lead to organ compromise. And then about 11% of patients had had targeted therapy, including things like BTK inhibitors, BCL2 inhibitors, or IMiDs. Again, small numbers, so we could not identify one strategy being more effective than another. And it's important to recognize that the patients that got bridged had worse prognostic factors at baseline. So many of them had worse performance status, more advanced stage disease, high risk IPI, bulky disease, elevated LDH. And not surprising, most of them would not have qualified for the ZUMA-1 study independent of having received bridging therapy. And I highlight that because there's been questions raised as to whether or not bridging is harmful to patients and whether or not it should be avoided. I think when we look at retrospective analyses, you have to recognize that these were just different patients with all the selection biases that account for some of the worst outcomes. Importantly, despite these differences in the baseline characteristics and differences in practice patterns, the toxicity of axi-cel actually appeared to be very similar, if not potentially even better, in the commercial cohort. And so what I mean by that is, again, lower rates of grade 3 or higher CRS, likely reflective of the fact that there was much higher use of tocilizumab and corticosteroids. Despite that, the rates of grade 3 or higher neurotoxicity were essentially the same. Now, there have been great debate as to whether or not earlier introduction of things like tocilizumab could actually cause higher rates of neurotoxicity, and that is based off of a single arm cohort reported by Fred Locke, looking at earlier introduction of tocilizumab with potentially numerically higher rate of grade 3 or higher ICANS. I don't necessarily subscribe to that. However, I do think that tocilizumab has not led to reduced rates of ICANS. There is a cohort in ZUMA-1 looking at earlier prophylactic use of corticosteroids, which actually resulted into lower cumulative doses of steroids. Again, if you intervene earlier, you're less likely to get to higher rates of grade 3 or higher ICANS, and then that may result in lower or less use of corticosteroids. So that's an interesting observation. Again, these are all single arm observations without randomized comparisons. But again, we are intervening earlier with more aggressive use of mitigating strategies. I think the challenge is that the median hospital stay was 14 days with axi-cel, and a third of patients ended up in the ICU. And likely that was reflective of the number of patients that had grade 3 or higher ICANS. The use of pressors, requirement for ventilation, renal replacement therapy, those were actually low percentages and were more consistent with these numbers. So about 7% of patients, and not surprising, those that had higher rates of CRS usually have organ dysfunction and did require aggressive ICU support. Whereas with the grade 3 or higher ICANS, oftentimes we're just putting them in an ICU setting so that they can be monitored more closely. It would be nice to predict who these patients are that are likely to require more close monitoring and higher use of healthcare resources. Administrators would love that. As I round on the CAR T service, if I could predict how my day is going to go, I would like that. Thus far, our numbers are too small. We've not done a good job of identifying who's likely to have rates of grade 3 or higher CRS or neurotoxicity, with some exceptions. Poor performance status, bulky disease. These have consistently predicted for higher rates of acute toxicity. In addition, Karen Jacobson had looked at inflammatory labs prior to infusion and peaks, including things like ferritin, CRP, and not surprising, if you proceed in a higher inflammatory state, those patients are likely to have acute toxicity. The good news is the response rates in this commercial cohort are very similar to what was achievable in the ZUMA-1 cohort. We've done similar analyses looking at T-cell and another consortium and similar findings that despite these differences in baseline characteristics, this therapy works and it can be done across multiple centers in the US. We do see some conversion similar to what was reported in the ZUMA-1 study of PR to CR, they all occur early. So none of the conversions were late. That now has led to many discussions. Should you get a scan at day 30 or should you just wait to day 90? Because day 90 is a much more stable response. And the patients that are in a CR at day 90, the vast majority of them are likely to remain in CR out to month 12. We still get a response at day 30, mostly to identify those patients that are progressing and also potentially to clear those patients who like to return to their originating center. So it's a lot easier to have a patient return home if they're in a good response as opposed to someone who's progressing. Again, in terms of duration of response, progression-free survival is very comparable to what was observed in the ZUMA-1 study, which was very reassuring, albeit relatively short follow-ups. We had about 13 months of median follow-up. You'll see in an update this year at ASH, surprisingly, the outcomes are better in terms of overall survival than what we observed in the ZUMA-1 study. I don't put a lot of emphasis on that because it's retrospective data, but again, at least we can achieve or reproduce the findings of what was achieved in these tightly controlled single-arm phase 2 studies. Again, we tried to identify baseline characteristics that were associated with improved outcomes. Performance status and LDH were some of the most robust factors. Now, we've been critical of our assessment as, you know, an LDH that's just slightly elevated as impactful as an LDH that's 2 times the upper limit of normal. No, those that are much higher clearly do worse. I'm still moving forward in patients who have an elevated LDH, but I have personally stopped taking patients who have poor performance status onto CAR T. And I think that's because their outcomes are generally worse, both from an efficacy and safety standpoint. Again, there have been other analyses looking at standard of care outcomes. This was the CIBMTR analysis, much larger sample size. But again, very similar outcomes to what was achieved in the Juliet study. I think the controversies that we're now facing is how do you sequence CD19-directed therapy? So Dr. Chesson mentioned tafasitamab, lenalidomide looks to be very promising, particularly in second-line large cell lymphoma with very favorable overall survival. We don't know if you can sequence CD19-directed therapy and have good outcomes. I would say at this point, we don't have anything to suggest that you would have unfavorable outcomes. We generally are getting biopsies in patients prior to proceeding to CAR T if they've had prior CD19-directed therapy, just to ensure that the target is there. But we also know that there are some CD19 negative clones that emerge even in patients who've not had prior CD19-directed therapy. Now that we have randomized studies in the second line suggesting that patients who are appropriate for transplant might do more favorably with CAR T, at least with axi-cel and lyso-cel, how do we define these transplant eligible candidates? And now is any patient in second line potentially a candidate for CAR T? Are we really going to be rigid and define them based off of the eligibility of the randomized studies? We debate regularly who is an appropriate CAR T-cell candidate. Outside of some of the factors I just discussed, we have a committee that convenes on patients when we feel that they may not be a great candidate. And what's our eyeball test? These are patients, as I mentioned, with poor performance status, with significant comorbidities, active autoimmune conditions, sometimes severe renal insufficiency or very low ejection fraction. Bendamustine in combination with polatuzumab and rituximab might be an effective strategy for some patients. We are starting to see some failures to manufacture post-bendamustine. So this is one situation where I do feel pretty strongly that you should not take a patient who's just had bendamustine and try to manufacture an auto CAR. And if you have a patient destined for CAR T, I would not do bendamustine. The question is, what about our follicular lymphoma patients? Should you never consider bendamustine? I think that we don't have enough data to inform that question, but particularly in the relapsed large cell lymphoma space, I am not pursuing bendamustine prior to CAR T in someone who I envision at some point will benefit from CAR. And then you've already heard the real promising findings of the phase 1 studies with bispecific antibodies that will likely have much more broader application, meaning administered outside of FACT accredited or transplant-like centers. There's still some challenges in terms of monitoring and treating CRS, though, as you heard, most of those have grade 1 or 2 CRS. The question will be whether or not all of those centers have to have tocilizumab. That's become a real challenge right now, given that tocilizumab is being utilized in patients with COVID and hypoxia. And so we're all panicking right now. Do we have enough tocilizumab for our patients that are being treated with CAR T and bispecific protocols? So we do need some more education and strategies to mitigate the CRS, even if it is low grade. And the question is, are the allo CARs at a point where we can replace the auto CARs? Thus far, all we have is safety data, essentially, that they do appear to be potentially safer, which is kind of interesting. Or again, it might just be that we're better at managing the toxicity. So back to our approach to large cell lymphoma in 2021. Again, maybe in 2022, we'll have something other than R-CHOP frontline. But for patients who failed to respond to salvage chemotherapy, we are moving currently to CAR T in third line. I think there is now debate as to whether or not CAR T will move into second line. We do question whether or not we proceed straight to tafalin in those patients who are not good candidates for salvage chemotherapy. I didn't show you data, but there's a pilot study looking at liso-cel in these patients who are not transplant candidates in the second line setting. It's a small cohort of patients, but CAR T can be effective and safely done in that setting. And then you heard discussion of many of the options now in that post-CAR T period, or for patients who are not CAR T candidates. So this is just good news for patients. It's becoming really challenging for us to figure out how do you approach patients in terms of, are there characteristics that will inform one algorithm or pathway over another? And how do you develop new drugs given the plethora of agents that are out there? You heard mention of CAR T in frontline. So Satfaniliput at ASH this last year reported the ZUMA 12 findings. There were some issues in terms of how that study was conducted. So it took patients with either high IPI or double hit, and after 2 cycles of R-CHOP, if they had a Deauville score of 4 or 5, they could enroll into a single arm sort of pilot study looking at axi-cel after 2 cycles of frontline R-CHOP or EPOCH-like therapy. The responses look to be quite good, but it's not randomized. The safety looked to be as good, if not better, than what could be achieved with ZUMA 1. The question was, now, should we do that for all patients even before exposure to chemo? And what about those Deauville 4 patients? Were they really destined to fail? So now the real headache is, how do you design a randomized study in the front line to address those limitations? 2 of the 3 studies in second line are positive. There's going to be a lot of debate as to why one of the studies was a failure. Does that mean that T-cell is a less effective CAR, or was it flaws in the study design that led to unintended sort of biases or variables that weren't accounted for? And then you'll have the diehards that are going to want to see an overall survival advantage before they change practice, though most of those patients in the Transform study crossed over. In the ZUMA 7, crossover wasn't allowed, but many of those patients who were on the standard of care arm went on to receive commercial CAR. So neither one of those studies show an overall survival advantage right now. Will that impact decisions? And then again, as I mentioned, in the third line or later space, can we exploit the mechanisms of resistance, or should we move forward with allo CARs? There is CAR T in other lymphoma subtypes, so you heard alluding to this. So KTE-X19 or Brexacel essentially utilizes axi-cel with some differences in manufacturing and relapse refractory mantle cell lymphoma. So the ZUMA 2 study enrolled patients who had had at least 1 prior line of therapy, but they also had to have failed a BTK inhibitor. So most of these patients had had frontline chemoimmunotherapy and then second line BTK inhibitor. They did exclude patients who'd had more than 5 prior lines of therapy, which was kind of interesting. And in terms of the manufacturing process, because mantle cell lymphoma, it's not infrequent to have circulating tumor, and because axi-cel is manufactured from PBMCs, There is an additional purge that occurs where they filter out CD19 positive cells prior to manufacturing. The rationale behind that is, one, you're removing the mantle cell lymphoma cells, but probably more importantly is that you're removing those cells that might lead to CAR expansion and exhaustion in the manufactured product before we even infuse it in cells. Because there is data emerging that the fitness of those T cells in the manufactured product is associated with outcomes. So single arm phase 2 data suggesting very high response rates, duration of response appears to be quite favorable, PFS and overall survival, again, quite favorable in patients who had failed a prior BTK inhibitor. So the next iteration is, can you move this into frontline in patients who have high risk features, including P53 mutation, blastoid variant? And so there are at least 2 studies about to launch right now that could potentially address that question. You saw some data with ZUMA-5 with his axi-cell and relapse refractory follicular lymphoma. There is more debate as to who's an appropriate candidate for CAR T and follicular lymphoma, given the number of options are numerous and actually quite well tolerated. We have thought that the POD24 patients are the highest yield, because these are patients that, whether or not you agree with the Kasula data, there's been some iterations that many of those patients were just transformed disease. But I do think there is a cohort of patients with POD24 follicular lymphoma that don't do well. And again, this was a sort of post hoc analysis looking at the patients in ZUMA-5, which were overrepresented with POD24. They don't do as well as the others, but they still do quite well in terms of their general outcome. We've just gotten spoiled at looking at these curves with CAR T and follicular lymphoma where median PFS hadn't been reached yet. You could also argue that the good risk patients, those that don't have POD24, really do quite well with axi-cell. And so again, we'll be debating, I'm sure, over the next few years, who's an appropriate candidate for CAR T and follicular lymphoma. We need longer follow-up. I'd like to see some stabilization of these curves. We do see more relapses occurring between month 3 and 12 with the low-grade lymphomas than we see with large cell lymphoma. There was data at ASCO this year looking at retreatment, which might be potentially effective in low-grade lymphoma as opposed to aggressive lymphomas. I also wonder how much the fludarabine as part of the lymphocyte depletion is contributing to some of this efficacy, and then we start to lose it. Whereas I don't feel that is contributing to efficacy in large cell lymphoma. So again, we need more follow-up, but I do think that CAR T has resulted in some of the best outcomes we've seen thus far in the relapse refractory setting. So my last slide here is, I will conclude that CAR T has clearly changed our approach to chemo-refractory large cell lymphoma and can cure patients. I also fully acknowledge that the logistics, the healthcare resource utilization is astronomical. And as a result, there is a large portion of patients that have never been considered or will never have this therapy. So we still need better drugs that are more readily available and potentially cheaper to use. And we need to figure out why over half of patients fail this expensive therapy. But again, there is nothing more satisfying than having a patient who you know is not going to survive 6 months, that's now 5 years out from our phase 1 component of the ZUMA-1, doing very well. And so CAR T is not going away. We just need to get better at delivering it, and it needs to be more cost effective. With that, I will stop.
Thank you, Dr. Nastupal, for an excellent talk. We are running out of time, so I would just request Dr. Ranjit Sahu from All India Institute of Medical Science for a question if he has. Ranjit, are you there?
Yes, sir. So I'm there.
Yeah. So,
my question is, I mean, it was a very nice talk, man, and it was pretty elaborate. You have to tell us what are the leukapheresis issues in such cases. You have cited that those patients who are treated with bendamustine, you had faced issues with leukapheresis. Now, what about those patients who have undergone autologous stem cell transplantation? That is my first question. And how will you, now there are 2 options for those patients who have failed R-CHOP. One is high dose chemotherapy for those patients who are transplant eligible. Now, now you got these 2 options. and now there are some results which are coming out that CAR T might be a better option. How to sort out these two populations? I mean, which patient should get what?
Yeah, good question. So the first question with the leukapheresis. So we have seen some issues with manufacturing, particularly with lyso-cell following bendamustine. And so you have to recognize that patients that are probably being considered for bendamustine and polatuzumab or rituximab are probably folks that were borderline in terms of being considered for CAR T. And so they may have some stabilization of their performance status. They may temporarily respond, and now they're being considered for CAR T. We have seen challenges in terms of manufacturing an auto product, particularly within a short window. How we define that window, I think, is a moving target, and we need a larger sample size and more data. But I generally think that bendamustine within 6 months is going to be a real challenge for manufacturing an auto CAR. Your second question in terms of who's going to be in a, how are we going to approach high-risk patients in the future as we have more agents move into frontline and we now have some randomized data suggesting CAR T might be appropriate in second line. I'm very much in favor of moving as many effective strategies into frontline as possible, because if we can cure more patients, then we don't have the headache of figuring out who's a CAR T candidate or where does transplant still fit in. I do think that the population of patients that start to fail some of these novel therapies might look different than those that are just chemo refractory. But as of today, any patient who progresses within 12 months of rituximab and an anthracycline, to me, those patients should be considered for CAR T as soon as we have that available to us, because those were the patients in the ZUMA-7 and TRANSFORM study. And without disclosing too much, particularly the hazard ratio of ZUMA-7 is pretty phenomenal. So I do think that there is a role for CAR T for those patients. Outside of that, I think we'll have to wait and see the full data set before we know, is CAR T appropriate for every patient in second line.
Thank you. Thank you very much, Dr. Nastupil. I think, Gaurav, can you take over from here for the case presentation?
Yes, so I think we barely have time for elaborate discussion. So I take opinion from two experts, Dr. Chesan and Dr. Nastupil. Do you think we can squeeze in one case, or up to you?
Yes.
Okay, thank you. So instead of two, let's do one case, and I would invite Dr. Prashant Ganeshan from GIPMER to present the case. And we will include Dr. Anshu's case in the next subsequent webinars for sure.
Thank you very much, Dr. Gaurav. Without much ado, let me get into this. Thanks for this opportunity. My case is a 74-year-old male with comorbidities of hypertension, coronary artery disease. He had a bypass about 8 years ago. He came to us about 4 months ago with bilateral orbital and multiple subcutaneous soft tissue swellings with a short history and no particular B symptoms other than that. He was in good condition and had these multiple subcutaneous nodules all over the body, ranging in size from about 1 to 3 centimeters. His labs showed anemia. Hemoglobin was 7.8. There was nothing specific on the smears. The renal and the liver functions were normal, and the LDH was okay, and albumin was about 3.2. So he had a biopsy from one of these lesions on the chest wall, which was initially kind of reported as a diffuse large B-cell lymphoma. But subsequently, the pathologist went back and they felt that some of the lymphoid cells were positive for CD5, and cyclin D1 was run at that point of time. It was diffusely positive. And they asked us to run a FISH, and the sample was run for a FISH 1114, which came positive. The rest of the investigations were negative. The bone marrow showed some infiltration with the FISH, showed the 1114 translocation. Here a PET scan, which showed diffuse disease, extensive involvement of multiple nodes. There was a lot of intra-abdominal involvement with mental and peritoneal deposits, and lung nodules, kidney involvement, stage 4 disease. So the final diagnosis for this patient was a blastoid variant of mantle cell lymphoma with a high VP score and a status post bypass. My questions for the panel other need for other investigations in the workup of this patient, and what is the best treatment approach you would offer for this patient?
So I think Dr. Jason and Dr. Nastupal can take one by one. So I would invite sir to your thoughts.
So I can jump in. So I would definitely want to know the P53 status. We see this not infrequently, that it gets called large cell lymphoma, and then it's just a really aggressive blastoid variant mantle cell lymphoma. I have the luxury of trials here. So generally we would put them on a BTK inhibitor based approach frontline. But this is someone I'd be lining up quickly for CAR T. I think we've debated, if we start to see signs that they're progressing or failing to respond, how narrow is our window to get them onto something else? But generally, chemotherapy, in my experience, including hyper-CVAD, it's not been particularly effective, or at least not for very long in these patients.
I do not disagree at all. The management of blastoid variant has been somewhat Neanderthal. The concept that more is better, keep hitting them harder and harder with transplant and hyper-CVAD, it doesn't work. And it is, as Loretta said, I think a BTK inhibitor with venetoclax, with R squared, hard to know which one is the way to go in a patient, particularly with the cabbage and other aging comorbidities. Not that I would call 74 old in the least, but I think this is just the kind of patient you don't want to subject to unnecessary toxic therapy. And if you can get him to CAR T, good for you. That'll be it.
Right. I think just to give the update, he had actually chemotherapy. He had a pre-phase, and after that we gave CHOP alternating with Arasi. He seemingly has responded. However, after the fourth cycle, he has developed pneumonitis, which we think is a drug-induced pneumonitis because all infectious workup is negative. So at this point, he is still hypoxic. Actually, currently he's admitted, and we are giving him some steroids, and he's getting better. But he's kind of not willing for further intensive treatments. So we are planning to start him on rutinib, and if we can source venetoclax, then probably we'll add that also. So any other suggestions at this point of time?
No, I think, the data, what was it, the Symphony trial, is that the name of it? Ibrutinib and venetoclax look very promising. It's hard to pay for something like that. I know everybody uses ibrutinib, but the data would suggest that zanubrutinib may be a bit more effective and is certainly less toxic in mantle cell lymphoma, even acalabrutinib. But certainly a BTK inhibitor would be the next go around and try and get into CAR T if you can. And, why do we need 6 cycles anyhow? I could tell you a story if we had time about why we use 6 cycles of therapy. It's kind of silly and empiric. But I think given the nature of mantle cell not being in general a curable disorder, I think putting him on a BTK inhibitor now alone or with Ven would be what I would do.
No matter how much we would like this to continue and the discussion to go on, but because of the limitation of time, I think we have to come to the end of this session. It was great to listen to both the speakers, and I would like to thank them to take time out to teach us. And especially a word of thanks to ASCO, Vanessa Charshe and Vanessa Eaton to make it possible. This collaboration, I think this is a good beginning. And with these few words, I hand it over to Vanessa Charshe or Eaton to conclude this, and because time is really, really short.
All right. Thank you so much, Dr. Gaurav. Yes, thank you everyone for joining the call today for this very robust discussion. Despite running out of time, I think we really covered a lot. Thank you so much to our speakers, Dr. Chesson and Dr. Nastupal, and all the esteemed colleagues we have on the call today. Let me just see. My colleague Vanessa Eaton has just shared in the chat a link to a very brief survey to collect your feedback on our session today. We will also be sending the link in an email to all of the attendees if you don't have time. But anyway, with that, thank you so much for joining, and we look forward to seeing you all again very soon.
Thank you.
Bye-bye.